So let me begin by welcoming everybody to the first inaugural session of the Asia Pacific Geriatric Oncology Society Molecular Multidisciplinary Tumor Board. So I think it is long overdue that we start paying more attention to the pediatric oncology needs, and especially an interaction between oncologists and geriatricians is of immense value. I just gave last month I gave a talk on geriatric oncology in Auckland, and they are probably having more greater difficulty than we are in whatever we are doing. And our initiative of bringing out the textbook, LCVR is almost signed up. So we will really have a good publication that will come out to LCVR. With these few words, I hand over to Prem, who's been coordinating these monthly webinars, and then we'll hand over to Dr. Tilak for the procedure. Over to you, Prem.
Yeah, so good evening, everybody. And yeah, it's indeed a landmark day today that we are able to sort of start our tumor boards. I think this was something which was, it should have, I mean, it was long overdue. And I think it's always been an ideal platform for geriatricians and oncologists actually to interact. And we're quite excited that we are able to start this. And I welcome the panelists. And of course, I welcome Dr. Tilak, who's going to be initiating our first tumor board here. So over to you, Dr. Tilak.
Thank you, Purishar, and thank you, Dr. Prem. And good evening and warm welcome to all of you. And greetings on the eve of the 83rd Independence Day of the country. I guess the year itself feels like a geriatric year. So 83rd. So we shall not waste much time and get to the basics quickly. I would like to introduce our colleague, Dr. Swati Batra, who's a surgical oncologist. She is an active member of our oncology team. We engage weekly in the multidisciplinary tumor boards at our hospital, and she brings a lot of value of her experience as well as her innovative ideas to the table. So Dr. Swati will be presenting an interesting case of a 77-year-old male, a retired senior Air Force officer who came with a non-metastatic transitional cell carcinoma of the urinary bladder with history of a Crohn's disease, putting us all into a spin as to how do we go about this management, deviating from the standard guidelines. So Dr. Swati, over to you.
Thank you, sir. I'll just share my slides. Are the slides visible?
Yes.
Yes, ma'am. Yes, ma'am.
All right. So this is actually one of the longest tumor board discussions I think we've had in a long time, because there were multiple aspects to this, both surgical and medical. So I'll jump right in. So this was, as sir said, a 77-year-old retired senior Air Force officer. And the comorbidities were Crohn's disease. In addition to this, he also had atrial fibrillation with controlled ventricular rate, was on regular medication for the same. The geriatric issues that he had comprised sensory neural hearing loss. He was using a hearing aid. Cognition was normal. He was ambulant without any aids and support, and had an excellent social support system. There was no frailty. So this gentleman presented to us with a history of painless hematuria and irritative lower urinary tract symptoms in May 2025. An initial evaluation was done for him, and these are the broadly the summary of the investigations. So a cystoscopy was performed, which showed a 3-centimeter tumor, which was not typically papillary in appearance grossly, along the left lateral and posterolateral bladder wall, was involving the vesico-ureteric junction and obscuring it. The tumor needed to be removed in order to visualize the orifice, and it was stented at the same time. A biopsy was taken, both superficial and deep. There were no other multicentric lesions in the bladder. Renal function was adequate for age. His serum creatinine was 1.2 milligram per deciliter, and creatinine clearance was a split renal function was done, and this showed 37% function of the left kidney on account of the hydronephrosis. The pure tone audiometry revealed, confirmed the sensory neural hearing loss, and colonoscopy showed a chronic quiescent Crohn's disease. The descending and sigmoid colon were also involved in his case. Hepatic function was largely preserved. These are the imaging findings. So both CCT enterography, urography, and a PET scan were done. So this confirmed the stage to be a T3, A or B cannot say, of the bladder with some extravesical extension and transmural VUJ involvement and upstream hydronephrosis. It was N0 and M0 at an evaluation. This is a scan which is demonstrating the upstream hydrouretronephrosis, and a stent can be seen on the right-sided image. So overall, we are dealing with an organ-confined disease with no nodal involvement or distant metastasis. So now on the CT enterography, we tried to see the status of the Crohn's disease as well. It showed multiple segmental lesions almost from the duodenum to the ileum. The ileum was the worst affected. However, the descending colon and sigmoid were also affected. And there were no signs of any active disease. And the severity can be called moderate. These are representative images as can be seen. And the other interesting aspect now to this, to confuse us further, is the variant histology. So the dominant pattern was a papillary urothelial in the 50% of the component, but it also showed clear cell, rhabdoid differentiation, as well as nested architecture in about half. It was a low immunogenic tumor. PD-L1 score was less than 1%, and HER2 results were equivocal. So now I think we'll go over to the discussion part, and I would request everybody to please chip in, and Tilak sir to kindly also take over.
Continue, yeah, you can continue, Swati. Yeah.
Right. So I think the way we look at it, the management decision framework for this, we will consider obviously this patient for a curative treatment pathways, but this could include one of the two, either a surgical pathway, radical cystectomy with a pelvic node dissection, with or without neoadjuvant and adjuvant chemo/immunotherapy, or a bladder preservation protocol, which would involve a maximal TURBT, which would be technically challenging in the VUJ area, along with concurrent CRT, so as a trimodality treatment. And then we can discuss the further adjuvant and neoadjuvant decisions with respect to both the chemotherapy and the immunotherapy. So the decision influence, just to recapitulate, would be the high-grade histology with divergent differentiation, involvement of the VUJ, Crohn's disease, which in his case is more than a comorbidity because it has strong bearings on both of the decision pathways, whether surgical or non-surgical, atrial fibrillation, and his hearing loss, which again compromises the chemotherapy decisions. His age, 77, but relatively good performance status, and of course the patient's preferences. And we must definitely address some of these points, and I'm sure the House would have others. One would be the radiation enteritis risk on account of Crohn's, the platinum ineligibility on account of his hearing loss, immunotherapy eligibility, whether he's eligible or not in view of his low CPS PD-L1 score, and the left VUJ, which puts him at a high risk of local failure if we consider a bladder conservation protocol. So oncologically, we know that these
Before
two
you
are...
proceed, can I ask you a couple of questions?
Yes, sir.
The atrial fibrillation, any treatment was ongoing at that time?
Sir, he was
No, it was a control ventilator, right, sir. He had a control rate.
No. Okay.
He did not have any thing, what do you call it, with high heart rate. He was controlled, and it was he was on anticoagulation and beta blockers.
So 2 medicines only.
Yes. Anticoagulation was
Oh,
given alongside because of his age and his high ASCVD risk scores.
and this hearing loss that was corrected by hearing aid.
It was not
Did it?
fully corrected. He was using a
Oh,
hearing aid, but he used to come forward and lean forward to listen.
okay. Okay. And no formal geriatric assessment was done.
Formal geriatric assessment was not done in this case. We did do the G8 score and as well as the
Frailty.
CARG scoring. So he was not qualifying in for a dual chemotherapy, and otherwise G8 scoring did not show any gross this thing of a frailty.
Dr. Anand has a question. Dr. Anand, you can ask your question directly.
Madam, was the patient already known case of Crohn's disease or it was diagnosed in
No,
your
no,
center?
he was a known case. Oh.
And was he on any remission therapy or?
He was an ASA, if I recollect, and Tilak, sir. He was not on any steroids. He was not on
No, he was not on
any,
steroids. He was not on steroids.
and no
Okay.
biologicals. Yeah.
No biologicals
Yeah.
also.
It was controlled his case. Okay, fine.
Mhm. So there has been an anonymous attendee who's written if cisplatin ineligible, then gemcitabine carboplatin with durva periop strategy. If eligible, sorry, if eligible, and cisplatin, and if ineligible, then EVP periop strategy. Okay. And adjuvant pembro nivo if not taking max strategy. So the question here is he's got an active Crohn's disease, not active, but he's got a history of Crohn's disease. So would we like to give him or will he tolerate immunotherapy in the background of the Crohn's disease? So if anyone from the panelists, Dr. Anant or Dr. Rajiv can take on this. In a patient with a known case of Crohn's disease, would it be okay to give Durva or a Pembro or a dual immuno?
I think a very interesting case for discussion to start with, as you told, the first case. So a lot of issues here to get into an optimal treatment regimen choice. As you rightly told, VUJ involvement, you will never get a maximal TURBT done. So the trimodality treatment is going to be very challenging. And of course, if you are going to use chemo RT, we need to use cisplatin. That is going to be he's already cisplatin ineligible. And the Crohn's and the bowel involvement with RT also we need to
Yes.
consider. So I think I will urge less towards a trimodality treatment because that most probably may not be a curative intent for him.
Yeah.
Coming to the option of neoadjuvant chemoimmunotherapy, as you rightly put up, is cisplatin ineligible. So gem carbo based chemo alone may not be sufficient as a neoadjuvant regimen. We have the Niagara trial, which shows gem carbo and Durva can be considered. And that trial, they didn't look at PDL1 status. So irrespective of the PDL1 status, there was benefit. So that may be one way to go. But the issue, as you rightly told, we will have to check with the gastro team whether the Crohn's is under control. Is he in remission? Or does he require treatment for Crohn's? Because you will definitely have issues when we use a PD-1 blockade when you're going to use it in the neoadjuvant way. But either way, he may have to get immunotherapy at some point of time. So another option would be a radical cystectomy so that we get some time to decide on the adjuvant immunotherapy straight away so that you get some remission for the Crohn's and go. But definitely not a straightforward optimal case for a curable intent. As rightly told, we may have to individualize here. And of course, as Purvis sir was telling, the patient preference and how aggressive is what they want to go. And even if you put a radical cystectomy, what is the conduit, all those things we need to be very careful here.
Yeah, so the question was this that, yes, Dr. Akhil and Dr. Prem have both raised their hands. Dr. Akhil, you can go ahead.
Yeah. So, regarding one point regarding the immunotherapy with Crohn's, actually the patient is not on steroids, not on any biologics, and we are
Yes.
planning only single agent PDL1 inhibitor. That means without any CTLA4 combination. So that has been a routine practice in patients with psoriasis and patients with PD and PD-L inhibitor are safe to be utilized. Definitely, we need to keep a closer watch on the symptoms. But the patient is not on steroids, not on biologics, so the patient is still a candidate for immunotherapy. Definitely, I completely agree. The patient is not a candidate of cisplatin because of the obvious reasons.
Yeah.
But gem carbodurva is not a very commonly utilized regimen, and Niagara included only cisplatin. So now we have data of EV plus pembro. That data was not there. That is also very preliminary stage. We don't know the exact data. So at the time of when we were planning this patient, I completely agree. We didn't have any sort of data for EV plus pembro.
EV
Now
plus
we have
pembro, yeah.
yeah. Now we have that data. At least announcement of that data. We don't have actual data till now. So I completely agree. It is a very difficult choice, but
Uh,
yes, the patient is seeming to be
the other
fit.
issue we thought was,
Yeah.
yeah. So the first question was that, do you think this patient would ever come up for a surgery with a background of Crohn's disease? I mean, if you plan a RCIC, even the ideal conduit with an active Crohn's disease, will that ever come up? Swati, as a surgical oncologist, would you be okay with even a moderately controlled Crohn's disease
No,
having a
sir.
segment of ileum as a conduit?
So unequivocally no, because I mean, one with the constant urine passage, there would be a flare up, whatever
Yes,
bowel segment is exposed. All
exactly.
segments are involved in his case, including the sigmoid, the descending, so which renders the gut not an option for a conduit in his case, because one is the strictures, the fistula formation, all of these issues are going to be there. It's going to be very hard to differentiate the flare-ups from the UTIs, so one will overlap with the other, and very high chance he'll
Yes.
need a revision surgery. So gut is definitely out in his case. And however, I mean,
What has
one
been the
option,
experience of surgical oncologists with cutaneous ureterostomies? I mean, how easy or how difficult are they to manage? We're talking about a 77-year-old male.
yes, sir. So, sir, in terms of ease of management, if I compare it to the bladder preservation, there are certain points in favor of the ureterostomy. One, it's a quick in, quick out surgery. That's number one. So just remove the bladder. The ureters are diverted outside as a bilateral ureterostomy. So two stomas, but small ones. The advantage of this is a ureteral stent can be placed, and with good meticulous techniques. The main concern with this is stenosis, especially in obese patients. Which is why most urologists don't use it as a primary diversion, which is why a condio is used. One is to give a single stoma, and second is to avoid the stenosis. However, in his case, it would be a very good option because it just needs a ureteral stenting, and maybe once in 3 months, the stents can be exchanged under local anesthesia, as opposed to a bladder preservation, which would also require a left VUJ stenting with frequent stent changes, which would require at least a spinal or a GA, which in his case, recurrent GA, repeated GAs is probably not a great option. So this could be a viable alternative. Plus, it gives another advantage that at a later stage, it will again give us time if we want to consider secondary reconstruction in his case. So at the
No, but
primary,
with the VUJ involvement, do you think you'll be able to get a R0 resection?
sir, so upper tract
With
is clear on imaging. Urogram has also been done.
left
Case, we should get away because it's a ureterostomy can be
VUJ
sited anywhere in the flank going up to the right iliac fossa.
involvement.
So we can take a good margin. We can send it for frozen section intraoperatively. So I'll
We're talking of a left hydronephrosis,
yes, sir.
right? We're talking about left
Yes, sir. Yes,
hydronephrosis.
sir.
So the stoma will be on the, which means you're going to cut short the left ureter.
So left ureter, we take a margin of about 4 to 5 centimeters. Ideally,
4 to 5
the
centimeters?
recommendation,
Yeah.
so that we can aim for that. We can judge by what length will comfortably be sited outside. But ideally, a negative margin is sufficient in this case because we're looking at a TCC, which anyway would be multi-field cancerization recurrent. So we don't really go all the way up regardless. So this could be a good option for him.
Right. Before we go on to the surgical management, Dr. Prem has raised his hand. Dr. Prem, yeah.
Yeah, so I mean, what was the current functional status of the person? And you said the person was not frail. So how did I mean, did you do a scale for it or was it only through G8?
Yeah, it was only to G8. We did not do the frailty scale. We should have done that, the complete CFS, clinical frailty score. Otherwise, the patient was active in the sense he used to go for his morning walks, he used to play golf regularly. He did not have any restriction of activities of any nature. And it was only for the last about a couple of months when she started having that hematuria, he got a bit worried about it.
Okay, and what is the family support?
Family, for the wife stays with him. The son is a cardiologist who is in regular, who does not stay in the same city, but keeps visiting him to see him. And he's got a good group of neighbors and friends who are willing to help him. He can fall back upon them.
Okay, I mean, just quickly before you go ahead, Dr. Athul, if you can also ask.
Yeah,
And
Dr.
then we
Athul has
can-
raised a hand, yes.
Hi, sir. The patient was having atrial fibrillation, and I think he was on anticoagulants, was he?
Yes, he was on anticoagulants, controlled ventricular rate. So, yeah.
So will that pose as a significant risk, I mean, post-operatively?
So perioperatively, like in any other case, probably what will shift him onto a low molecular weight heparin and then peel off the last dose of heparin 12 hours before the surgery and keep him on beta blockers. And post surgery, once the drains are clear and within 24 hours or 36 hours, we should be able to start with low molecular weight heparin again. Swati?
So usually we start even 12 hours after.
Yeah.
If
As long as the drains
intraoperatively
are
it's
okay.
been, yes, sir.
So that should not be a problem by itself. Um, so that can be
Because
handled.
even other patients who are on anticoagulation, if I just set apart the age, it's a very
Yeah.
routine policy to do a bridge therapy with LMWH and then kind of go back.
All right.
So,
Do
so
we know
But
the
in
reason
yeah.
for the atrial fibrillation?
Come again, sir?
What was the cause of the atrial fibrillation?
It was there's no underlying
Okay.
hypertension or anything like that. Nothing. No structural heart disease.
And how many years after retirement was he?
He must have retired at the age of 59, and this is 77. Sir. So yeah, about
So just because I don't know, I'm asking. In senior officers in the armed forces, usually their fitness level even after retirement is quite good. Right?
yes, sir.
Yeah.
They generally get hooked on to golf during the senior cadres, and then that keeps them quite fit, even otherwise. Yeah.
Nowadays, the alcohol consumption is less, but
Yes.
maybe at the time when he was serving, his consumption did it have any importance on this case?
We did take a detailed history. He did not have a what should I say, socially awkward drinking or any alcohol
Right.
abuse kind of
Fair
thing.
enough.
Harmful use of alcohol, what we call. There's no
Okay. Right. Thank you.
right. Sir. So Dr. Akhil also posted that RT seems to be clearly out because of two reasons. Patient is not for cisplatin and risk of enteritis. Absolutely. So surgery at we did discuss surgery, but because of the lack of the consensus on the ureterostomy, as well as a definite no for the ileal conduit, this patient was not offered radical cystectomy as upfront. And then we discussed the other options with him. Swati, you can continue and let's go on with the case and what happens.
Sir, I just brought it to the case discussion, but
Yeah, yeah.
I'll just state what happened. So he went on to receive neoadjuvant chemotherapy. So if you could share the details. The
So,
gem, yes.
yeah, he got gemcitabine with carboplatin for about 2 cycles. And I think thereafter he has actually gone on to concurrent
Radiation.
chemoradiotherapy, which
Yes,
he
sir.
chose.
So
Which he chose.
he,
So,
yes, sir. He received via the IMRT technique, so via AI adaptive planning. I think which was, if at all, bladder preservation, because I think the family, they also sought multiple opinions. And I
yes.
think they were leaning towards preservation or to take a chance with it. Although salvage cystectomy in these cases does tend to be even more challenging and I think probably less feasible. So they elected to go for preservation and they've completed radiation as of now. He does have grade 2 toxicity. So the irritative symptoms have increased for the bladder. There's no proctitis as such per se, so no flare-up of IBD with the radiation. And so I suppose if radiation is on the cards, then IMRT is almost essential with all the modern VMAT if possible, and IGRT and adaptive planning with the bowel displacement techniques and everything would be essential.
True, true. Dr. Anand also says about the considerations for quality of life after surgery, age expectancy, and cardiac toxicity of chemotherapy in view of atrial fibrillation. Absolutely valid points, Dr. Anand. The quality of life after surgery for a person who's otherwise been fit and going around, and suppose he has a ureterostomy kind of stoma, that would obviously hamper his quality of life. But if it is life-saving, probably we can offer the advantages and maybe he gets convinced. Age expectancy, he's doing well so far. So we expect that he should be, I mean, without the disease, he would have done quite well for another probably a decade. And cardiac toxicity of chemotherapy in view of atrial fibrillation, yes, the drugs which are cardiotoxic were not planned to be used in this case. Though he had atrial fibrillation, but a structurally normal heart, so even hydration would not have been a problem otherwise. Yeah, Dr. Prem.
Yeah. So what was his will actually? The person himself.
What all?
What was his will? What did he wish in the treatment
So
part?
he wanted to keep his bladder. He wanted to preserve his bladder. So he said, okay, I'm going to take the risk and I'd like to go with the radiotherapy. At this point, our radiation oncologist did dwell deeper into the thing, and there was a new place. These people are ECHS empaneled, so they have access to private centers for our radiotherapy. So there was a new AI-based planning machine in one of the centers. So they got in touch with those radiation oncologists there. They discussed commonly, and they said, okay, let's put him on an IMRT with an AI-based planning, so to minimize the toxicity. He's done well. I think he's due for review probably next week. He's just completed his RT. I haven't met him
Yes.
in the last 3 weeks. So seems to be doing well. Swati, have you had a chat with
Sir,
him?
I spoke with him about a week back.
Yeah.
So at that point, he had just concluded his radiation, and his concerns were the
Irritative
irritative lutes
bladder symptoms. Yeah, that is an issue. Probably even a common garden person who gets
Right.
CTRT.
But
Dr.
thankfully,
Anant,
no hematuria
yeah.
or infections.
Dr. Anant, any points from your side?
No, it was great discussion. I, I mean, if I would just think of myself in the same question, and the one thing that you would look at, I guess, is life expectancy prior to, him choosing a treatment option.
Yeah.
And assuming it's around 5 to 7 years, and there was a small possibility of, a non-surgical approach. I mean, that's what you would consider, which is what the family has gone with.
Yeah.
I also think he was an ideal candidate for a whole CGA as well as
Perfect.
his and a complementary ASA. The PAC that is done for these patients is pretty
Yes.
good, and that would have given us an idea as to his actual risk from
He
a
was
medical
in
as well
ASA
as
3. He was in ASA 3.
yeah.
as
So
per
that
his-
further would have, I think, pushed the decision to maybe, let's go towards a non-surgical approach. So, those were 2 points that came to me. Otherwise, yeah, that's about it.
I
True.
have
Very
another
interesting.
question here, sir, regarding the radiation. So again, it's a toss-up. It's like no option is really optimal in his case, because but then with the divergent histology and the ureteric transmural involvement, I don't know, like
What
what
will be the
efficacy
effect of the
would,
RC?
because under other circumstances, it's probable comparable oncological results. But with these two factors, the radiation efficacy also sort of little questionable.
Yeah, I agree. It's not a common garden urothelial TCC, which probably would have responded in the expected manner now with the 20% clear cell and all these things. It does.
Yeah, the standard protocol we would have used for fitter patients would not fit him under any this one. So it's a chance either way. I mean, I think that's something that the treating people as well as the patient would have understood, I guess.
So the other point about CGA is a very valid point, and this especially emphasizes the point why it is now very, very important to have a geriatrician on board in a oncology clinic. In our hospital, unfortunately, there is no geriatrician posted. Me, with my limited geriatric knowledge, post my training and a little bit of practice at CMC, etc. So we do need a dedicated team which can do the CGA, probably do the G8 even before the patient sees the oncologist. And based on that, we send the patient for a CGA, and the team does the CGA, and you review him thereafter by the time the patient comes up for tumor board. I think that was the right way to go ahead. Any inputs from the our geriatricians on board?
While they're thinking, let me say that I'm a little skeptical about the AI part of radiotherapy, not specifically for this patient, but in general, because there has never been any evidence documented that AI-driven radiation is better than whatever we are using so far.
This is the first patient who went
There's a
for it,
lot
and
of
so yeah,
lot of what we call AI washing, where the term is used as AI, but there actually doesn't exist any artificial intelligence behind it.
so even we were not clear as to what was the AI model which was helping them in their radiation, but that's what they suggested, and I said, okay, if this is the best is available right now, let's go ahead for that.
What I was made to
So,
understand
Sir,
that
on
the
that, sorry.
AI-based planning, sir,
Yeah,
it is basically the speed at which the plan is generated. So basically, every day they will have a real-time plan being generated. So that may help in case of bladder, sir. As you rightly told, there will never be randomized evidence in radiation oncology, but the technology seems feasible for moving organs like lung and bladder, because it may help us in getting a real-time plan quickly. That's what they say. There are 3 to 5 plans for the radiation oncologist choose on a daily basis, and then they choose it. That's what the AI helps. That's what my understanding is.
Yes.
So on the subject of AI, if I may take the liberty, I did query AI with this case also. And I asked it to query all the available literature and various guidelines and figures. And if you'd come up with some sort of quantitative analysis to help us with the decision making. And this is the weighted score it sort of came up with in favor of surgery in this case.
Wow.
Not to say that it is sacrosanct, but since we were on the subject. So,
So we're getting back to AI decision making like that one which was there about a decade back, which was it? I'm forgetting the name also right now. Right. So in this case, finally, the patient underwent concurrent chemoradiotherapy, and we're just waiting to see the evaluation. And like she says, surgery is going to be challenging in case he comes up for that.
especially in his case, we also have
Any
to think
other
of one
thoughts
more
by our
thing.
geriatricians before we move on?
Well, considering that he has a very mild frailty status, considering that he had a very good performance status before, prehabilitation is very much feasible in such patients, actually, prehabilitation, because after the therapy, what I see here is that most of the patients, especially in the case of Crohn's disease, I'm talking specifically in case of Crohn's disease, the greatest loss in quality of life is by the bowel symptoms.
Yeah,
that's what they have, and the severely impaired nutritional status. So a combination of physiotherapy combined with a good nutritional support should significantly complement the outcome.
Right. I think valid point. Yeah.
And also, I wish to know the concurrent part which was given with RT, sir.
If I'm not wrong, I think he got carboplatin along with RT because we could not give cisplatin, and gemcitabine also was taken as probably slightly more toxic than carboplatin. So yeah, definitely not optimal, but that's what he got.
Yeah. So sometimes we prefer utilizing mitomycin 5-FU, which has a randomized evidence in bladder. Concurrent gemcitabine we have found to be very poorly tolerated due to repeated thrombocytopenia. So sometimes we utilize mitomycin 5-FU, or definitely might or might not be fit for due to cardiac issues also, but usual preference is towards mitomycin 5-FU in patient is not fit for cisplatin.
Right. I think that would have been an option in his case because heart was otherwise okay, except for the AF, which is controlled.
Correct.
Yeah.
Correct.
Right. It's called plan of the day. That's AI you're talking about, Dr. Akhil?
Yeah. So actually what happens, there are 5 plans are generated and kept ready. according to the bowel position and other things. The best plan which is matching the bowel filling, that's matched by AI, and it's called the plan of the day. It is selected automatically by AI, and it is cross-validated by a physicist. Yeah. So I have actually background of radiation oncology. So
Oh,
that is
nice. Oh, great. Yeah, that's value addition to the Tumor board. Thank you, Dr. Akhil. Appreciate it. Thank you, Swati. Nice case, intriguing case, and it actually kept us. Like you said, it went on for almost 45 minutes to an hour just for one case. We normally finish off in 1 hour, 3 to 5 cases, but this went on very long. So thank you. I think it's been a smash hit case for the inaugural session of the Tumor board. So right. So my second case is by and large a common garden case, but it's got some geriatric issues. So I'll start with the presentation. May I have my slides loaded, please? Right. Yeah, we can start. So our patient is a 65-year-old male, a resident of Tamil Nadu, just primary education, informant is self and son. His reliability is quite good. Next slide, please. So he came with some pain abdomen, constipation, and backache, and he was quite upset in the OPD. He was kind of more worried about his abdomen. He was looking a bit dazed. And so my colleague who was in the OPD decided to admit him and then evaluate as to what's wrong with him. Continue. Next slide, please. So this was diffuse, non-radiating, and colicky, and used to aggravate during constipation, and it was relieved with passing of stools. Next slide. Constipation, basically was unable to pass stools more than once in 3 to 4 days. He used to strain, have a feeling of incomplete evacuation, required laxatives and enema, and no history of any obstipation or any vomiting. Next slide. He had predominantly lower and mid backache, which was non-radiating. It was aggravating with movements and was partially relieved with analgesics, and pain was often more at night as well. Next. And he had unintentional, unquantified weight loss of over 2 months by the time he presented to us. Next slide, please. There was no history of any fever, night sweats. Next slide. There was a known case of type 2 diabetes, but he did not have any history of any tuberculosis or hypertension. Next slide, please. A reformed smoker, social alcohol consumer. He consumed mixed diet and history of straining for urination and increased frequency, poor flow while urinating. Next slide. No family histories of malignancies or any genetic disorders. Next slide. Here he was an elderly male. He was conscious, but he appeared very dazed and disoriented while in the ward. And it was quite prominent that he's not a normal 65-year-old male who is coherent. And he complains of pain, and he required complete assistance for his activities of daily living as well as instrumental activities of daily living. He was moderate built, afebrile, vitals were normal. There was bony tenderness over the dorsal and lumbar vertebra on examination. Next slide, please. His abdomen was soft, and there was a hard swelling, which is not been mentioned here on the rectal examination of the prostate. His suspicion of his days, we did a Montreal cognitive assessment. It was 7 out of 27, mainly in the executive, visuospatial, recent, and working memory. Though there was no focal neurological deficit, there was no evidence of any Parkinsonism. Next slide. His chest and his cardiovascular system are normal. Next. His investigations revealed routine hematological and biochemical parameters as within normal limits, except a raised ESR, raised LDH, and a serum PSA of 150 nanogram per ml. Next slide. Next slide, please. His ultrasound, next slide, revealed a grade 2 prostatomegaly with hypoechoic areas in the prostate. Next slide. And a simple renal cyst. Next slide, please. And a CT abdomen revealed a homogeneously enhancing abdominopelvic lymphadenopathy with the prostatomegaly and irregular lobulated contour along with thickening of the posterior wall of urinary bladder with indistinct intervening fat planes with the perivesical lymphadenopathy and mesorectal deposits. Next slide, please. So these are the images of the CT pelvis, which shows the bladder and the prostate, with the irregular and enlarged prostate and loss of fat planes with the urinary bladder. Next slide. These are the sagittal and the coronal images. Next, it's showing multiple bony lesions also and abdominopelvic lymphadenopathy. Next slide, please. His PSMA PET scan revealed PSMA avid heterogeneous lesions, multiple 6.4 into 4.5 to 7.6 centimeter total, SU of 29.9, and diffusely invading the prostate, bilateral seminal vesicles, mesorectal fascia, abutting the anterior wall of the mid and lower rectum. Next slide, please. Of course, with multiple pelvic as well as retroperitoneal lymph nodes and multiple bony lesions. Next slide. And this is the PET image showing extensive bony metastasis and prostatic lesion with loss of fat planes with the anterior wall of rectum as well as the urinary bladder and bony mets. Next slide. So in view of his MOCA score, which was low, evaluation for probable coexisting dementia was asked for and done. The MRI brain surprisingly revealed diffuse asymmetric meningeal thickening with enhancements and multiple varying sized calvarial enhancing lesions, part of the metastatic disease, suggestive of calvarial and dural metastasis. Next slide, please. This is the MRI brain, where you can see the skull table is thickened out, and there are hyperintensities inside the lesion, suggestive of dural, the calvarial metastasis, as well as the dural lining can be seen as thickened. But there were no features of any lacunar infarcts or any other features. Even the entorhinal complex was slightly reduced, but there was no gross abnormality as such to typify a typical dementia of this age, in the age of 65 years. Next slide. So the neurologist wanted to have a CSF analysis. We got a CSF done for him. Cytology revealed essentially a normal kind of a CSF, including the malignant cells. There were no malignant cells, and the meningitis panel also was sent. It was negative. MTV PCR was negative. Next slide. So a partial finger-guided biopsy was done for him. It revealed that SNR Gleason 4+4 of 8. Perineal invasion was present. There was no LVI, and there was periprostatic fat invasion as well as seminal vesicle invasion. Next slide. This is a representative image of the core biopsy. You can see the islands of tumor cells within the prostatic tissue. Next slide. And the higher magnification showing loss of the glandular kind of epithelium of the prostate and showing more of sheet-like cells. It's consistent with SNR adenocarcinoma. Next slide. Yeah, so the issues to discuss in this case mainly are the clinical evaluation of concomitant dementia in elderly with cancer. So may I request Dr. Athul, or if you can, how would you suggest that oncology should go about? Because we do see patients who've got either a baseline cognitive decline or do develop cognitive decline during therapy, and we may miss these patients if we don't pick them up early.
Yes, sir. In my opinion, in this patient currently, yes, he does have cognitive decline, but first I would like to correct the correctable causes. He was having hyponatremia, so I would like to take care of that first. And I think he was having hypocalcemia. I don't remember the labs. I think he was having hypocalcemia also. Was he having hypocalcemia, sir?
He did not have any hypocalcemia, I mean, at least not manifested clinically. I will check the lab reports. Even the albumin was okay, 3.9. But yeah, he was having borderline hyponatremia, which we addressed.
Yeah, and probably so from a geriatric perspective, I mean, obviously he's frail and he's having very severe cognitive decline. He's completely dependent on ADL and IADLs. He also has metabolic derangements. So the main line of treatment from a perspective should be patient-centric or the family-centric, which means what their decision matters, and to minimize the unnecessary interventions to the minimal. And again, the prognosis is very limited, and the focus should also consider palliation.
What screening tools can we use? That's
Yeah.
the thing for the audience. What screening tools can be used to just exclude or probably suspect a coexistent dementia in a patient with cancer?
Yes, sir. So basically, whenever we screen someone for dementia, the first thing we need to know is that all the correctable causes have already been corrected. Then you can administer the scale for dementia. For example, someone is having hyponatremia. Obviously, you have to correct the hyponatremia and then screen for dementia. And in case of dementia, the usual way we approach is that you can, mainly in my OPD settings, if the time is limited, we screen with something like MiniCog or MMSC. MMS is a very reliable screening tool for assessing cognitive decline, and depends on the functional status. If the patient can communicate with you properly, then we do a detailed evaluation using MOCA or Adam Brooks cognitive examination, etc. However, the core principle in screening for dementia is to first interview the patient. Once you have corrected the causes, that can lead to temporary cognitive decline. Again, coming back to the hyponatremia cases. Now, this patient has, I think, dural metastasis, dural mets also. So, considering that fact,
also,
So, considering that fact, it is less likely that his cognition is going to improve from the current baseline. And even though it's a bit debatable, yes, I would like to control his pain, because pain management, dural meds and pain, obviously you should be able to give palliation. And rather than opioids, you can consider something like gabapentin in those cases. And in case of severe pain, yes, you are allowed to give opioids. And considering the very severely restricted activities of daily living, I just like to underline the fact that we will be proceeding with giving high importance to palliation.
So very, very right. I think the correctable causes once corrected, I think in the OPD at least, I find this MiniCog actually quite easily doable.
Yes.
If I'm not wrong, it has about, I think, 3 questions. Just draw the clock and a couple of
and
more
then ask them to recollect.
And recollect. So that's quite easily doable and quickly done in case of a busy OPD. And of course, even MMSC will take that little bit of time of whatever 5-7 minutes, and MOCA, of course, a bit more longer. So that can be done. We do see patients who probably might be having some amount of dementia and who come up with a new condition which has got a delirium. So what should be the approach in such cases to see whether it's just his pre-existing dementia which is worsening, or it's something else which is added onto the? How do you see the delirium dementia complex in geriatrics?
Yeah, definitely. Actually, in vast majority of the population with dementia, they present to us with delirium. So a patient who has not even dementia, even mild cognitive impairment, suddenly developing some UTI, then they will easily go for delirium. So in such cases, obviously we in the place where, in the hospital where I work, we do have trained rehab. We have a rehab psychologist, and they are trained in dementia or delirium prevention measures. Okay. Apart from the underlying correcting the factors, for example, adequate pain control or correcting the metabolic abnormalities, exposing the patient to sunlight. So we have a battery of interventions prepared with us for delirium prevention, basically supportive cares given to people with delirium. As to your second part of your question, whether there is an underlying case of dementia, we might be, many of the times it will be a bit difficult for us to know. So as with any neurologist, the good history brings out all the diagnosis. Even as to what type of dementia it is, everything will be revealed to you in the history itself. For example, the patient is having a history of hallucinations early on in the disease. That could suggest something like DLP. The patient is having episodic memory loss. That could suggest Alzheimer's. If the patient is presented with falls or movement disorders, again, we have to consider for Parkinson's. So the history definitely goes a long way, actually.
History always helps.
Yeah.
In such cases.
Yes, sir. So,
and
that is how we approach.
Of course, using the screening for the CAM score or something like that, which for delirium.
Yeah, for delirium we use 480 or CAM score. In ICU we use CAM ICU score. The purpose of this course is to tell you if delirium is present or not. Yeah, but most of the time, if the delirium is if the cognition is fluctuating over the course of day, that itself is a good indicator that the patient is in delirium. You don't even need to administer the course.
Yeah, great, thanks. So, Dr. Prem or Dr. Anand, can you just touch upon the cognitive enhancers, and if any of the oncologists regularly use the cognitive enhancers? I see our radiation oncologists use cognitive enhancers for patients who get in brain RT, though they try hippocampal sparing RT, etc. But what's the role of cognitive enhancers? Dr. Prem? Yeah, Dr. Anand?
Sir, I don't have much experience in this cognitive and post-radiotherapy. So I think Dr. Prem will be or persons working in oncology will be better persons.
Yeah. So in our hospital, memantine is very commonly utilized actually. So and there have been memantine studies also recruiting at both TMH Mumbai and TMH Varanasi. So memantine is one of the cognitive enhancer which is very commonly utilized. It has some data also, though the data is not so convincing, but it is still utilized, and a randomized trial is looking into it from TMH.
Oh, okay.
I would like to agree with Dr. Akhil also in that regard. We in our center also we do use the memantine, and the recent trials using memantine is also pretty promising. There are some centers which actually are trying with the pyracetam and citicoline combination, though the evidence is very much limited. For example, it's mainly used in stroke wards, for rehabilitation.
Strokes, the neurologists use it very frequently in strokes.
Yeah, but now it has shown some results in vascular, any dementia of vascular origin. This pyracetam citicoline combination is given BD dose.
Like a neuroprotective agent, yeah.
Yes, neuroprotective agent. And high dose vitamin B12 also has been shown to have a good effect, positive effect on the cognitive outcomes as well.
Oh, yeah. Okay. Yeah, Dr. Prem, you raise your hand. Dr. Prem? Right, while he comes back online, Dr. Rejiv, metastatic prostate cancer in the elderly, I mean, how often do you use upfront chemotherapy plus ADT in patients who have got a high volume disease? How do you sequence the therapies in your cases?
Yeah, so I think your statement itself says that, if it's oldest told that we are treating or, slightly elderly, then the guidelines varies. So if you look at the regular NCCN guidelines, then it is a very clear case of yours, which is high volume disease, which requires a triplet therapy. But we know in geriatric oncology, we have a lot more other issues to look at. You said your patient is from Tamil Nadu. He has dementia. He may go into delirium. So I think we need to tailor. That's what the SIOG guidelines teaches us, that you don't have to have one plan for everybody. You need to individualize for the frail and elderly. So here my concern would be to, again, as the geriatrician correctly told, we should not get him into delirium. So I will not use opioids much, especially tramadol or other drugs. We need to be very careful. We need to reduce polypharmacy here, because being dementia, he may not take drugs like relugolix, which has to be taken regularly. So I may use, if he stabilized, a 6-monthly or 3-monthly injection, so that his travel from Tamil Nadu to Bangalore can be reduced.
Absolutely.
And after discussion and after patient preference and what is the outcome here, ADT alone may be an option, reducing oral. And because enzalutamide and other newer ARPIs also has its cognitive and the drowsiness and the tendency to fall. So all this, I think the SIOG guidelines are very clear that we need to individualize, and there is no one fit all guidelines like NCCN, which we usually follow.
True. So he's 65 and with such extensive disease, with his background of dementia. Do you think surgical castration will be an option in this case?
Yes, I think, again, I would like to know the extent of dementia, because when we work closely with the geriatricians, they say that if you have a severe dementia, then and you have only a non-critical prostate cancer, your overall survival will depend, endpoint will be dementia-related issue. So
Yes.
in that case, surgical castration will definitely be an option. It's one time. You need not visit the hospital, frequently. And after discussing with the patient, if he's fit to undergo a minor surgery like orchidectomy, that would be a really good option. And from this point of view, cost may not be an issue because he may be reimbursed. But otherwise, again, if the cost is an issue, then again, orchidectomy would be much cheaper than prolonged medical castration. Yes.
So we did discuss this, but we felt that doing it on a spinal anesthesia with such extensive meds would be difficult to put him in a position to give spinal.
No,
So,
I don't think we should do it straight away. Maybe once he stabilizes, 3 months,
exactly.
6 months down the line, at some point we can. Yeah.
True. So we just put him on hormonal therapy, and we just somebody asked what is the ideal pain relief protocol. So this patient surprisingly did very well with the fentanyl patch. He did not get a good relief with the paracetamol, and of course gabapentin was continued, and with tramadol. But with fentanyl patch, he kind of actually slept quite well with the night. So we continued him on fentanyl patches, 25 microgram per hour every 3 days. So, Dr. Akhil, I would like to say something about.
Yeah, so sir, as I was trying to highlight that here cranial penetration, we like to utilize drugs which have least cranial penetration. So darolutamide is one of the safest drug in that regard. Doesn't increase seizure potential also. So daro will be a preferred option, can be utilized in such a patient. And definitely, ADT alone with such high volume disease is going to control it for hardly 6 to 8 months to the max.
Yeah.
The patient is comparatively not so old. He is just 65, if I remember correctly. So,
65.
yeah. So I would be tending towards adding ARPI as well, if feasible and affordable.
That was another point of discussion. How do we tackle the dural metastasis? Do we actually give him any RT for his, dural as well as calvarial meds, or just intrathecal is out of question? Or you just give him systemic therapy and hope for the best? So that was another point of discussion while managing this case.
Yeah, that is a very important point. However, the problem is that dural metastases are most of the time not confined to one point, and they might be diffuse and patchy.
Like in his case, it's patchy.
Yeah. So it's unlikely to be of significant use to give radiation to that part.
Absolutely.
So that is why we'll be trying to intensify the systemic therapy with least complications, and our team might not benefit and might also complicate this other situation.
Yes, so we just left it at that. So let's give him about 3 to 6 months of ADT and see what happens, how he does. Take care of his family, explain them the care of a dementia patient, and then call him back in and see what more we can do for him. So that was the decision of us. So any other points
I
from
think
anybody?
another issue.
Yes.
I think different we may treat is we usually in elderly, very elderly, where as you rightly told, chemo and other most aggressive options are not there. We bring in PSMA PRRT much earlier. So it's one time, and once only in 2 months. And usually it
with
gives
adequate bone marrow reserve, they should be able to.
Yes, and good pain relief will be there if that is the primary intent. So that's another thing which
So you have been using it upfront first line?
No, not first line.
Not first line.
So if it's ADT
early, you bring it up early.
We bring it up early. Yes.
Got it. Yeah, Swati, Dr. Swati has raised her hand.
So just about the surgical parts of the orchidectomy, if at all spinal and all these things are contraindication, case like can be taken up under local anesthesia also.
Oh, lovely.
That is a possibility.
So that's one more we can plan in case he's doing otherwise okay.
Yes.
Before we go in for something, we can one-time surgery. Yeah. Right. So that's what about the 2 cases for this tumor board. Any queries? Any questions?
Tilak, I just had a question.
Yes,
This patient thankfully did well with the fentanyl. In patients with this kind of bone meds, how comfortable are you using, because they're older, and usually bone meds don't respond as well to opioids as they do to NSAIDs. So I just want to know on the panel how they feel about that, because I do give short courses of NSAIDs, and I think it helps dramatically. But
Yeah, it does. But only thing was the routine use of NSAIDs in geriatric population with the kidney issues. So we give it on a SOS basis in our hospital. We don't completely deny it, but we give it on SOS basis. He does get paracetamol, but if you're talking of diclofenac or ibuprofen, that is given on an SOS basis. Any opinion from our geriatricians? Dr. Anand's got a very valid point.
Yeah, I mean, I do think that Dr. Anand has got a valid point, and a short course of NSAIDs are generally justified, actually, especially in from
Acute pain
arising from bones, acute pain arising from bones, and also I would also like to reiterate that NSAIDs also help in improving the appetite in malignancy. So they do have a positive outcome, and that will help in at least temporarily improving the nutritional status as well. But yes, as long as the patient is not having any gastritis, you can give NSAIDs, because again, they are notorious for causing very severe gastritis.
Dr. Prem?
I think we are looking at what stage of disease and what treatment also. Purely if pain is the most important thing to take care, then in geriatrics, risk-benefit ratio is always taken into consideration. So if pain is the one which is the most important part at that particular stage, then looking at purely side effects of a drug might not be the right way to go about. And SIDS are always a problem, but short course can always be taken. Of course, just a quick point on cognitive enhancers. I think it's ultimately what it is what options we have now. As something is better than nothing is what we are looking at. So all the three drugs that we even mentioned, I hope that we have more data, because ultimately it will help us. And even non-pharmacological cognitive training, depending upon the extent of cognitive issues, should also be sort of trained, because ultimately that is something which we can always do. Because if there are already a lot of diseases, then drugs to add more medicines is not always easy, especially in an older adult with cancer.
True. Just for the sake of one year, adding on one for each illness increases the pill burden. Yes. IDDS. What's that, sir? Dr. Parekh, sir, you mentioned some IDDS.
He was talking of the intrathecal drug delivery systems for
Oh,
pain
intrathecal. Oh, okay. I didn't get that. Oh, okay. Is there above? Okay. No. So we had one patient of metastatic CA lung whom we put a Omaya reservoir recently, and he went on quite well for about what 3 months, and thereafter had progression and he passed away. Yeah. Spinal cord stimulation, none, sir. None, Swati. Right, sir. So with that, we come to the end of the first tumor board. Back to Dr. Prem and Dr. Parekh.
Yeah, so thank you, Dr. Tilak, for actually having two wonderful cases which were presented by you and, of course, Dr. Swati. And thank you, all the panelists. I think it was a cracker of an opening. And don't forget that this is only the beginning. So the next tumor board is on September 11th. So looking forward to all your active participation and presentation. So thank you. Good evening and good night. Thank you.
Thank you, everyone.